Okay. Alrighty. So, hey everyone, this is Kim E, the Diabetes MP, and I am back with another commentary over the ADA 2022 ADA Standards of Care. I am trying to do again, like if you tuned into the first one, I'm trying to stream to my YouTube channel, so I have that here, and then here's Instagram here. A couple of days ago, back on Monday, I did a commentary over Standard 1 of the ADA Standards of Care. And for those who don't know, American Diabetes Association every year comes out with new standards. They normally put them out in December for the following year, for the year to come up. And so I've been reading them, and there have been some exciting changes and updates. In Standard 1, there wasn't much of a difference between last year's Standard 1 to this year. But the one that I'm going to be talking about today, Standard 2, is classification and diagnosis of diabetes. And there is a update that we all should take heed to, because there is a big change in something. Now, let me give a disclaimer, right? I am not summarizing the standards of care. I am not going to read through the standards of care. Simply what I'm doing is bringing out some things that I found to be very interesting, any changes that would affect the masses, and so that's what I'm going to do. Last commentary that I did on Standard 1 went a lot longer than what I wanted it to, so I'm not going to do that. I'm going to try my hardest not to do that, okay? And so, anywho, let's get right into it. Standard 2 is a little bit more lengthier than Standard 1. And it basically goes through what is classified as diabetes, the different types, and how do we go about screening? How do we go about diagnosing those who have prediabetes as well as diabetes? Now, one of the things that it comes out of the gate saying is that classifying diabetes is going to guide your therapy, because depending on what type of diabetes a person has, that's going to let you know what the treatment is going to be. And so it's, of course, we can think off the top of our head, you have type 1, you have type 2, and then you have gestational diabetes. But quite frankly, there's a lot of different types that are within that. There are type 1 is actually an umbrella, and there's other types that's in it, like LADA. And then also you have some exocrine, involvement as well. And if you go through and you read it, you'll see many of them you probably won't come across in practice unless you worked with that specific population. So out the gate, it's talking to us about, making sure it's very important that you as the provider know what type of diabetes that you're dealing with, so you know what type of treatment to go forth with. Now, here's the thing, and it actually says this in here. Many times, it's very common for people to be misdiagnosed. Their type to be mistyped. So, I'm not going to get into all the particulars, but LADA, for instance, many times people are misdiagnosed for, let me go through in my head. They're misdiagnosed and as type 2. And then you realize that actually they're not type 2 because they don't get better. And so now they're under the umbrella of type 1. And then you have MODY, which can have, characteristics of both type 1 and type 2. And so it's a nuanced thing, right? And so it comes out the gate and it tells you that, yes, we have classic symptoms like type 2 tends to present like this, but it can present another way. And that is how you figure out what the type is. And it's just a course correction. Nobody is going to throw you away or put you in jail because you did the wrong type. it's very common for people to start out being diagnosed as one type. I have personally met a lot of adults that in their 40s and their 50s, they've been treated for type 2, and actually they have LADA, or maybe they have type 1, and it's all because diabetes was picked up diabetes was picked up and they were treated as what we see in adults, which we tend to see type 2 a lot in adults. But I digress. So that's first things first. One of the things that they definitely highlight there were slight changes in just language that I noticed. And what I mean by that is, as you probably can tell across industries, not just in the medical industry, there is there's attention to how we speak and how we label people. You shouldn't label people, but the way that you speak about people, there is a healthcare language involvement going on. So basically, the proper term is not to call someone diabetic. Actually, the more proper term, the more politically correct term is to actually say a person with diabetes. And I noticed that the language a little bit was different from last year to this year. They did that, but I noticed that they said more of patients with diabetes last year, but this year it was more people with diabetes. And here's the reason for that, guys. When it comes to what we call labeling people, that's what you do if you call somebody a diabetic. That's what you do if you call somebody obese. It's actually, the proper term is person with overweight, person with obesity. And I know that's a shift because many of us have gone through school and, language is going to it will catch up. But that is the shift that is happening, just so you know, those are the proper terms. And they definitely do that in these writings. You'll see that the term diabetic is not used. I don't think a lot of people would find that offensive, but it's more of a labeling. It's kind of like, I'll give you an example. Okay, and I can say this because I'm a Black woman, but that's like me being in a job and somebody saying, Kim the Black, or Kim the Black girl. You would find that offensive. So if somebody is saying, Carol the diabetic, they're putting it in the same category. And I hope that makes sense. Okay, so that's how I was able to wrap my head around it. So, but regardless of back to what I was saying, regardless of what type a person has, regardless, we know that hyperglycemia happens in all types. And whenever there is hyperglycemia present, there is risk for complications. And I think sometimes we can think about complications mainly in type 2 diabetes, but people with type 1, they can get the same complications: neuropathy, kidney issues, eye issues, cardiovascular issues, same thing. It's not because of the type, it's more of the hyperglycemia. It's not the type, it's the hyperglycemia. So that was something that I wanted to kind of point out, because I know in just talks, people can really separate it like that. Of course, you have charts about the criteria of diagnosing. What many people don't know, or I don't know if a lot of people know this, honestly, but I know that we use the A1C to diagnose. You don't always have to use the A1C. That's not the only diagnostic test. You can use here it says that you can use a fasting blood sugar. You can use a 2-hour blood sugar, like if it's like an OGT test, OGT test, yes. That's what pregnant women, if you've ever been pregnant and you've ever done your glucose test, you can do that. You just don't have to do that in pregnancy. You can give your patient that. Now, how convenient that is? No. The reason why we opt for the A1C is because it is convenient. It really is convenient. And so anyways, so it talks about that and how you would go through, diagnosing it. And the big thing is that you need to confirm the diagnosis. You can't just go off one test. Now, many of us probably do confirm the test, because typically when we draw labs, what do we draw? We draw a CBC, we draw maybe a CMP, we do our lipids, we do an A1C. Well, that A1C counts as one test. And then in that CMP, you get a glucose because it's been fasting. So that's your fasting plasma glucose. So many times in one sitting, you can confirm a diagnosis just by running those two tests. But basically what it's saying is just giving you the guidelines of whatever you get, you need to confirm. That's it. You just need to confirm. If you get one test that's abnormal and one is normal, repeat the one that's abnormal. Okay. And if it comes back normal, then you need to monitor. You need to be monitoring, But if it is abnormal, then you can go ahead and diagnose diabetes. Okay. And so it goes into next thing one here is that it goes through the A1C. And I believe everybody is good with A1C. Just a couple of things to just understand is that though the A1C presents a lot of advantages, it does have a lot of limitations. There are certain cases that you would not get an A1C. And some of those cases would be in pregnancy. Some of those cases, people who have HIV, sickle cell disease. Because you got to think about it. What does the A1C do? It gives us the indirect measure of glycosylated hemoglobin. So basically how sugar-coated our hemoglobin is, basically. And so if you have a condition that there is a high turnover of red blood cells, it's reading immature blood cells. And so quite naturally, you're going to have a lower reading. So in that case, the A1C is not reliable. So that's when people have, a huge blood loss, when they're very anemic, they get erythropoietin treatments and stuff like that. You wouldn't want to get an A1C there. You won't want to get an A1C there because it's going to run low. And I know I had a patient that did have sickle cell trait, and she was on all the bells and whistles when it came to diabetes, lots of insulin, maybe 2 or 3 orals, and her A1C was like 6.2. And I'm like, I don't believe that A1C. So basically in this section, that's what it outlines basically, is that it has limitations and that you should know what your limitations are and what to do in those situations. You should have what they call it. You should run the test where there's like the assays or no interference. And, the lab that you send it off to should be certified, which typically they all are. The ones that we typically use would make, concessions for that, but you wouldn't want to get the A1C on patients that fall in this category. Something that they outlined this year that I did not see last year, as I did a quick comparison, is that it said, I'll read the statement here. People should consume a mixed diet with at least 150 grams of carbs on 3 days prior to the oral glucose tolerance test. Fasting and carbohydrate restriction can falsely elevate glucose level with an oral glucose challenge. And it actually mentions this a little later too about, before a person goes for a test, and you think about that, I think I can see patients trying to eat better around lab time. I don't know if you've had patients that actually say that to you, but, they'll eat good like a week prior. And, it can give you a false reading. And I didn't notice that in the standard last year, but I see that they mentioned it not once, but a couple of times here. So that's something to take note of. It goes through, your main category. So your type 1 and the risks for that, right at this point, the biggest risk, some of it, they don't know. We don't know. We can't anticipate who's going to, have type 1. But they have found a very strong family link. And if a person in a family already has type 1 diabetes, you can test the other relatives, closely related relatives, to see if they have the autoantibodies. And if they do have the autoantibodies, you actually, you can assume that they would eventually develop type 1 diabetes. And in here, it also gives you the different stages of type 1 diabetes. This is something I don't remember really talking about in nursing school or my nurse practitioner school. Don't quote me. I've been out of nursing school for a while. But it does break down the different stages of type 1. And really, you got stage 1, stage 2, and stage 3. A lot of times we find people in stage 3 because they're exhibiting, DKA, and they're exhibiting, all of the classic symptoms. But in stage 1, the only way that you would pick up stage 1 is if you just happen to test a family member. They have no symptoms. They have great blood sugars, but they have autoantibodies. That's stage 1. Stage 2 would be what you would consider their blood sugars would run the same numbers that prediabetes would run. They call that dysglycemia, that maybe you'll check it one day and it's normal. Maybe you'll check it another day. It's not normal. It just kind of varies. And then, of course, the autoantibodies would be present. And then, of course, type 3 is when they have the symptoms. And that's when we typically see the presentation. Is what we normally see is type 3, stage 3. So that's that on that. Let me make sure that I covered that. Yes, I did that. And then it gets into, well, you can't see it, but prediabetes and type 2. And it goes into talking about the screening, going through talking about the diagnosis and what's actually happening there. But here is the big update, the one that I really wanted to talk about. Last year's standard said that we should start screening anyone who's 45 and older. Now, there is a chart right here that tells you all the criteria of when you should start screening people. Like, what would classify you to screen a person? One of those items is anyone that's 45 and older. That was last year. But this year, it's anyone that's 35 and older. So that's a 10-year jump forward. Last year was 45 and older. This year is 35 and older. That is a huge update. So anyone that's 35 and older should be screened for diabetes. That's a big one, okay? Yes, you said you didn't even know there were stages to type 1. Yes, they actually outline it. It's very simple to, if you think about it, once you see the chart, you'll understand it. You'll be like, okay, I guess that makes sense. But there are stages to type 1. We just tend to see type 3. That's when we know a child, because typically you see it in type 1. Children have type 1. Typically they're presenting with DKA, and that's when we classically see it a lot. And that's stage 3 of type 1. So, anywho, but going back to the diabetes type 2, that is one of the hugest updates. There's some others that are going to be coming in other standards, but in this one, that's a big one. We should start screening 35 and older. Okay. Just so you know, just for kicks and giggles, I'll go ahead and read off other criteria because one of the things that I have seen is that, for those who don't know, I do trainings. I do like corporate and healthcare system trainings, and I'll have, a small group of like administrators, and they're needing a specific, answer or problem solved, big with optimizing healthcare teams, big with patient engagement, how to engage patients in chronic disease. One of the things that a lot of people were saying that they are having an issue is that a lot of people are not screening for preventative measures. So people are not picking up prediabetes, and that they're getting a lot of people that have diabetes just in regular, we're just regularly just seeing them. But it's like, how many people can we capture that have prediabetes so we can prevent the diabetes? Because they were finding that their providers were so burnt out, managing diabetes. So they're like, okay, how about we start putting more efforts into prevention, which is very good. And so I directed them to this chart because there are people who, should be getting screened that don't present the way that we think that they're going to present. So, as I told you, 35 and older, they should be getting screened. Okay. Now the big one is anybody who is with overweight or obesity, meaning that they are 25, their BMI is 25 or higher, and for Asian Americans, 23 and higher, their BMI cut point is lower. We'll talk about that a little later. But if they are overweight, if a person is overweight or obese and has one of the following risk factors, those risk factors are first degree relative with diabetes. part of a high-risk race or ethnicity. That would include African American, Latino, Native American, Asian American, Pacific Islander. Okay, well, I think we know that. History of CVD, cardiovascular disease. Okay, and in a later standard, they're going to define what CVD actually is. So hold your horses. If a person has hypertension, meaning that they have hypertension defined as more than or equal to 140/90. Okay, there was a change a couple of years ago where it was 140/80, and now, and in some, this is the ADA. You may find in other organizations they may have, like I think ACE has a little bit more stricter control over the blood pressure, but just so you know, here it's defined more than or equal to 140/90. Then if their HDL cholesterol is less than 35 and or their trigs are more than 250. Any woman that has PCOS, okay, because there's insulin resistance with PCOS, for those who don't know. If there's any physical inactivity, if you got a person who's overweight and they're inactive, they get screened. And then any other clinical condition that will cause someone to be insulin resistant. So severe obesity, acanthosis nigricans, and that's where you have this velvety kind of skin lesion in the folds on the back of the neck, in the folds of the arms and knees and things. You can see it a lot when it comes to people who have a little bit more melanin in their skin, Black people, Mexican people, not Mexican people, just anybody who has Latino people, I'm sorry, but anyone who has a little bit more. You can see it in people who don't have darker skin, but you can really see it in people who do have darker skin because it's more of like a velvety patch. Some of you probably have seen it in practice. Okay, so that's the first criteria. So anybody who is like that. The second one is anyone who is already testing as having prediabetes. Then any woman who has been previously diagnosed with gestational diabetes, she is going to be screened, Of course, I told you about 35. You begin testing at 35. And then anyone who has HIV, their medicines, some of the medicines can render insulin resistance. And then it also notes here that any results that are normal, testing should be repeated at a minimum of 3-year intervals. And this gives room for your clinical judgment, because you may think 3 years, that's a long time. If I've already had this suspicion that I need to test them, why would I wait 3 years? Clinical, okay, decision, y'all. You know your patients, you know what's going on, make that clinical decision, okay? And then something that was said last year that's worded a little bit different this year is that anyone that has the presence of prediabetes, you should have very swift cardiovascular testing and monitoring. And it actually says prompt comprehensive screening for cardiovascular risk. That's really what we're doing here. When you're doing diabetes management, we're trying to rather prevent diabetes if they have prediabetes or at risk for it. But then if they already have diabetes, we're trying to prevent complications. One of the biggest complications are cardiovascular issues, right? So, and they walk right there together. So if someone is already having any sign of some type of hyperglycemia, even if it's just in the prediabetes stage, you need to be really swiftly monitoring them for cardiovascular risk, okay? Of course, you may or may not know, I believe you would know, prediabetes is the most common type. Prediabetes type 2 is the most common type of diabetes. And so it's like 90 to 95% of people who have diabetes have type 2. So it is going to be the most common one that you're going to see. And then they give you a printout of a very simple, but are you at risk for type 2 diabetes? And it's very, your patients can fill this out, and you can put this in part. This could be a part of your patient forms, or your MA can fill this out. And this is a good idea this gives you a good idea if it's a person that needs to be screened as well. So they give you a lot of parameters of like who you need to screen, right? Let's see here. And I think, guys, I did want to talk about the BMI, the decreased BMI. So, catch this statistic, right? So, it is saying here that there is a finding that 1/3 to 1/2 of diabetes in Asian Americans is undiagnosed. And it suggests that the testing is not occurring at lower BMIs. And that is one of the reasons why they dropped that cutoff, because they were noticing that where everybody else, or the rest of the population, was at 25, people were not getting screened for diabetes because, they weren't hitting that cutoff. And so they decided to lower that BMI to 23 because so many people were going undiagnosed. And that's what it says here. It's evidence that, people were not testing. They weren't testing people because they weren't hitting that BMI cutoff. And so that is something to note, and hence why, and it does. And everything that you're going to read is going to have kind of like that twofold. It's going to say like BMI for, BMI 25 or more, and then 23 or more for Asian American or anyone of an adjacent population. And so you'll see that. The rest of this goes into a lot of the more, I would say, like more lesser common types. For those who don't know, I'll outline it for you. I'll just tell you quickly. Kiddos, because typically people who have cystic fibrosis, they for so long, many children were not living into their 30s and 40s. At some point in time, many of them were coming out of their adolescence. But at this point, people are living longer. But cystic fibrosis does put people at risk for diabetes. And they classify it as cystic fibrosis related diabetes. So there's a whole section on that. For anyone who's worked with anyone that's had cystic fibrosis, when I was in nursing school, I was a nursing assistant at the Children's Hospital, and I worked on the respiratory floor. And that was pretty much every kid that came in there, they had cystic fibrosis. And one thing about children that have cystic fibrosis, because of all that mucus and how it involves the respiratory system, they burn a lot of calories. And you'll see many of them are very small because they burn a lot of calories. And so going about them, think about that challenge, the challenge that will present with someone who has diabetes, but they're eating a lot because they need to get their weight up. And it's a different type of train of thought than what we typically think about with diabetes. And then there's also post-transplantation diabetes mellitus. So people who have just received a transplant, and there's certain types of transplants that put people more at risk for hyperglycemia. The thing that they do say is that people should really be kind of stable before we're really testing them, so after they have healed and they are on their medicine, they're on their regimen of medication. And in these situations, post-transplantation and cystic fibrosis, A1C is not appropriate. They actually say that you should get an oral glucose tolerance test. Okay. So, and then of course it goes into MODY and your neonatal diabetes. And again, it's very niched. These are not very common. So the average clinician probably would not see this. But if you're interested in it, I definitely say go right on ahead and read it. Is there a post-chemo induced diabetes? I'm not really sure. It's not outlined here. It's not outlined in the standards, but I will tell you this. This is what I will tell you. They do have inpatient, and I want to say maybe a later standard may outline cancer treatments, but not in this standard here. This is more so talking about the more higher arcing ones, with a little bit of the less common ones as well. But it goes through that. Of course, it talks about gestational diabetes, which there is a whole standard devoted to diabetes in pregnancy. So it's not just gestational diabetes, because gestational diabetes is a person who develops diabetes in the second and third trimester. That's what gestational diabetes is considered. But then you also have people who have pre-existing diabetes. What do you do with women that already have prediabetes? Okay. What do you do with women that develop hyperglycemia prior to second trimester? It's not considered gestational until it's second and third trimester. And so it walks you through all that. That's a whole standard, and we'll talk about that in the future, okay? So, guys, that's all I have for you for standard 2. I'm looking over here at my YouTube stream, and I'm already at 30-something odd minutes. I'm really trying to get this down to about 20 minutes. So, sorry that I'm so long-winded, but this one was a little bit more lengthier. I tried to get through it a little quicker than the first standard. And again, probably the next time I come on here, I'm going to do 2 standards, because standard 3 is not that long, and we can probably knock that one out quick. My hope is that I can do this tomorrow. Again, guys, I am a busy nurse practitioner and a wife and a mother, so I'm trying to get on here and be consistent. So if there's a day or two that lags, please forgive me. But I will be coming on, and we're going to get through all of these. And if you are not over on my YouTube channel, I'm streaming live here on YouTube. If you don't know that I have a YouTube channel, it's Kim E, the Diabetes MP. I have made 2 or 3 years worth of videos over there. So I would love to have you over there to be a subscriber over there. If you're not following me over here at Instagram. And then I'm also very active on LinkedIn as well. My name is Kimberly Ellis, a Diabetes MP. So that's where the Kim E, the Diabetes MP. So on LinkedIn, you'll find me there. And so anywho, guys, I am going to let you all go. I'm about to get in a workout, and I will talk to you guys soon. All right, bye.